Great, thank you. We really appreciate the opportunity to be here and talk to you guys about this project, which we think is doing some really important work to get these data out to community partners in a more timely fashion and to get more data out to community partners in a way that's easily used and understood. So we're going to start with, we put together a few slides just to give a little bit more background and context, but we want this to be a conversation, really. We'd love to hear from you about what your ideas on it are, what your data needs are. But we want to start with a little background just so that we're all on the same page in the conversation. So I'm going to share my screen. Let me know if you're seeing the presenter view because sometimes that gets mixed up. Yes, I think you are, right?
Yes, yeah, we see the presenter one.
Okay. Display settings, swap. Okay, actually, I'm going to share it from the other screen so that I'm not looking over there when I'm presenting.
And do you want to start recording at this point, Jen?
I did. I'm recording.
Great.
Screen. There we go. Now I think it should work. Where? Okay, there we go. So you're seeing the right one? Awesome. So thank you everyone for having us today. As I said, we are here to talk to you a little bit about the project before we go into a more open discussion just about our work and about your ideas around it, your ideas about data accessibility and what kind of data gaps there are. So like Will kind of mentioned in his introduction, this project really started just over 4 years ago with the FASTER project. And I'm sure we all know by now that the CDC loves their acronyms. So FASTER is the acronym for Firearm Injury Surveillance Through Emergency Rooms. And in late 2020, the CDC's Division of Violence Prevention funded 10 health departments across the nation to work on this project, including the Oregon Health Authority. So Dagan is here. He is on this project with us and he's from the Oregon Health Authority. And then the Oregon Health Authority contracted with us at OHSU to work on the project as well. And so it's been a great collaboration starting with that FASTER project. And initially the FASTER project, the goals are largely the same between the two projects. We are working to enhance the quality, monitoring, and timely reporting of non-fatal injury data and share that data with community partners. But the FASTER project was specifically focused on firearm injuries. Now we are into the AVERT project, and AVERT is the acronym for Advancing Violence Epidemiology in Real Time. And the AVERT project builds on the FASTER project, but expands it to other violence-related injuries beyond firearm injury. And like I said, the goals are largely the same. It's just a new era of it. We're expanding to a wider range of injuries. And Oregon is one of the 12 state grantees for the AVERT project funding. So the AVERT project will provide timely and actionable data at the state and local levels to enhance our prevention efforts. And we anticipate that these data can be used to demonstrate the burden and context of violence-related injury in Oregon, shape and evaluate violence-related injury prevention programs and policies, pinpoint emerging trends and allow for a timely response, and help secure funding for existing and new programs. So we hope that the data can be used by community partners in a variety of ways to support their work. And these are just a few of them that we see as potential applications. Now, the AVERT data are collected using Oregon's Syndromic Surveillance System, or Oregon ESSENCE, which ESSENCE stands for the Electronic Surveillance System for the Early Notification of Community-Based Epidemics. Oregon ESSENCE is a system that collects near real-time information on cases of reportable health conditions from most emergency departments and urgent care centers across the state. So what happens is that each participating facility transfers de-identified data from their electronic health record system to Oregon ESSENCE daily. And for our purposes for AVERT, we then use these data as specifically the data that they submit related to violence-related injuries. In reality, there is another step to this process in our pathway. So the emergency departments report their data to Oregon ESSENCE and we access it, but it doesn't stop there. like we said, one of the major goals is to share these data with community partners. And so in that aim, we've created a faster data dashboard, which we're going to show you and talk more about today. And the faster data dashboard really focuses on the firearm injuries that were part of the FASTER project. We're currently in the process of developing the AVERT Data Dashboard, which will expand to other violence-related injuries, including the firearm injuries. But AVERT just started this year, and so that's still in development. So we're going to show you the FASTER dashboard today, just as an example of what we hope to have with the AVERT dashboard and what we have now. But as we've developed the dashboard, we've had a kind of ongoing process of gathering community feedback and disseminating the data. So during FASTER, we conducted 41 conversations with community partners from a variety of fields and disciplines. We wanted to really reach a diverse group of voices. We reached out to those working in suicide prevention, those from rural areas, those from BIPOC communities, those in the business sector. We just really wanted to get a sense of how different people are using these data and how they are interpreting these data. And these individuals were able to provide feedback on our presentation of the data, their perspectives on the problem, and their data needs. And the feedback, the advice that they provided was then incorporated into our presentation of the data on our data dashboard. And we are continuing to incorporate their advice into our development of the AVERT Data Dashboard. And we hope to continue with these kinds of community conversations as we continue to develop the AVERT Data Dashboard. As I mentioned, AVERT expands beyond firearm injuries to other violence-related injuries. So we will be including a variety of violence-related injuries on the dashboard. But given this process of community partner outreach we follow, we wanted to roll out the syndromes kind of one by one. And the first one that we are starting with is firearm suicide or firearm self-injury. Hence how we first got in contact with the Alliance. And so for our rollout of each syndrome, we are really taking the time to look at what data are currently available out there and what are the current data gaps that we may be able to fill with the dashboard. And as we roll out each syndrome, we want to talk to people involved in that work, and in this case, in work around firearm suicide prevention, and see what their data needs are, what would be beneficial to them, what kind of context needs to be on the dashboard to really tell the complete story. So that's what we're working on right now in our development of the AVERT Data Dashboard. But some of the things that we've heard from our community partners in our conversations during the FASTER phase of the project is that they want us to include an explanation of the why. Talk about why the data show the results that they do, including providing that historical context behind the racial disparities and injury rates, talking about historical policies like redlining and sundown towns that have contributed to what we see today. Provide the socioeconomic context of health, including discussion of wealth and education gaps, and show where the injuries are occurring, as well as supplementing the data that we have from Essence with other data sources as needed in order to give a more comprehensive picture of the problem. Additionally, many community partners that we spoke to in these first years were aware of the lack of non-fatal firearm injury data and the time lag involved in obtaining firearm injury data. And they were enthusiastic about this opportunity to have access to near real-time non-fatal firearm injury data. Additionally, with the non-fatal data, they understood that they can present a more complete story about the impact of firearm violence in Oregon, and which could be used for advocacy and education, as well as for correcting false narratives, like the idea that gun violence is an inner city or gang problem or it's a moral problem, and reducing the stigma around gun violence. One organizational leader actually explained how data can confirm for community members what they know is happening anecdotally, which can serve to engage them in the process of generating solutions and advocating for change, which we think is super important. We really want these data to be able to be used for public health interventions and for driving change. When asked about the non-fatal firearm injury data variables that would be most helpful, many community partners brought up factors such as intent of the injury and geographic location in order to detect hotspots or areas to concentrate their efforts. Information on age and race and ethnicity, and just more information on intersecting identities. We also received some comments about the limitations of the data and the importance of acknowledging it and being transparent about it, as well as using other data sources to try to fill some of the gaps and bridge those limitation gaps. So all very valuable feedback, and this is just a fraction of what we heard and what we learned. And all very actionable things that we were able to then incorporate into our faster data dashboard, and that we are working to incorporate into our AVERT data dashboard. Now I'm going to pass it over to Will to talk a little bit about the validation process. We just wanted to give you a little bit of information on that process. As we know you're all data people, so we thought it would be appreciated.
Yeah, thanks, Becca. So a little more background about the syndromic surveillance data that we get and how we detect firearm injuries within that data. The two main fields used for that in the syndrome definitions created by the CDC are discharge diagnosis codes. So primarily IC10 codes, but IC9 and SNOMED codes are also included within the definition. And then also terms from the chief complaint. So that would be things like gunshot wound, terms like I was shot, etc. So it uses a combination of those fields to detect. There's an overall syndrome definition, the CDC firearm injury V2 definition, which would detect any firearm injury. And then there's also 3 intent specific definitions for assault. They call it intentional firearm injury, but that would be self-harm, suicide, self-harm, and then unintentional firearm injury as well. So for FASTER, we went through and manually reviewed the about 2,600 firearm injuries that were detected by that overall CDC firearm injury V2 syndrome definition. We found that overall syndrome definition did a very solid job of detecting firearm injuries. I should be clear here that specifically for these syndrome definitions, a firearm injury is caused by a bullet. It's a penetrating injury caused by the bullet, and so it excludes other injuries that are caused by the force of the weapon from firing the bullet. And that was dictated by the CDC. Probably most important here for this group, so the intentional syndrome definition was found to have a very low sensitivity and positive predictive value. A lot of this is dictated by the IC10 codes that are used. The validity of the intent specific codes is known to not be great. A lot of the codes by default, or a lot of the injuries by default, get a code for unintentional firearm injury. So work to improve this is ongoing. And the chief complaint, I guess I should add, for those self-harm injuries isn't normally specific enough to pick up that it was a self-harm injury. So we've worked to use machine learning methods and natural language processing to pick out these self-harm incidents. And then also we're using data linkage and as well as supplementing with other data sources to try and better understand the issue or the numbers related to self-harm firearm injuries in Oregon. Is there anything I should add, Becca?
No, I think that was great. And we have slides for this, but I would much rather just pull up the dashboard and show you that way. So I'm gonna switch gears and share that screen. So here is our faster data dashboard. Like I said, the AVERT one is not done yet. So we don't have the one that we don't have that one yet, but we do have our faster one up and running. And it gets updated quarterly. And I just wanted to walk you through it, show you some of the components of it, so you could see the kind of information that we're providing, and we could have a conversation about what else would be useful, any other factors related to the dashboard that may help with our development of the AVERT dashboard. So some of the feedback that we got from community partners was that it's too text heavy, and we are working on that. I'm sure you all know the challenge of saying everything you want to and need to say and not having it be text heavy. So we're in the process of working on that, but this is our homepage of the dashboard. We just provide some of the information on what Oregon Faster is, what Oregon Essence is. And then we have a technical notes page that provides some of the information on the background or any information. I was going to say that's not it. We have some the technical notes page that users can go to get more information about the data that they're seeing, such as like what is it that Oregon Essence collects? It's emergency department and urgent care data. We also have these more descriptive or text pages because, like we said, community partners really emphasized the need to have context behind the injury and to present that historical policies that contribute to racial disparities, and to present information on the socioeconomic conditions related to firearm injury risk. So we have a page dedicated specifically to providing some of that information. And as we roll out the AVERT dashboard, we plan to have like each syndrome or injury type will have kind of its own subset of pages, and will have its own page providing information more on the context for that injury. We also have a page talking about the public health framework and the socio-ecological model, which community partners thought was very effective. They really liked this focus on how can we use these data for prevention, and what is like the public health approach to prevention. So we have a table just kind of walking through some strategies related to prevention. I think that this page is helpful because it provides that like, well, we see all these data of firearm injury, but then what? What can we do? What is happening already? So I think that that's a nice addition. And then we do have the Faster Data Dashboard at a glance, which provides all of the which provides a lot of the charts just very basically, with just the charts to look at. But we also have then the extended dashboard. So if you click there for an in-depth view of each graph, one thing that I think that community partners found very valuable is that we didn't just provide that page with the graphs, but community partners raised that there is a wide variety of data literacy among partners working in prevention. And for some partners, that page with just the graphs is perfect. They can look at it and that's what they want. But a lot of other people wanted more of the explanation of, okay, what am I seeing here? And so we added text blurbs to really be able to provide that context and help people understand what these data are showing. So this graph shows firearm injury data, firearm injury emergency department visits by year. And one nice thing that is why I wanted to show it to you this way as opposed to just in slides and screenshots is that these are pretty interactive. You can scroll over some of them and get more information than just what's showing. So you can get these tables of specifically about breaking it down by sex or age group. So yes, we provide it by year, by month, and we have it for the different years. As you can see that we've been updating. And again, we have a little description of what people are seeing. So outlining the sharp increase from April to July in 2020, and how firearm injuries tended to be highest during late summer, early fall months. We also have information on intent. Like Will talked about, our ability to understand intent through Essence data. is very limited, given the limitations around the intent related ICD-10 codes in the data. So as we move forward in the AVERT dashboard, we are planning to expand, like Will said, to determine intent in other ways, such as through our data linkage and through other data sources. We also provided information on age and sex, as well as race and ethnicity. And in our paragraph about race and ethnicity, we also compared to the census categories, which are what you can see in blue here, as the percent of the Oregon population, based on census data. And one big thing that community partners brought up is that they want to know more about the location of the data and that it's super helpful for them to have county level data. So we created maps. This map shows the count or the number of emergency department visits by county. And again, if you roll over the counties, you can get more information on the number of firearm injury visits. And we also added the number of firearm deaths to the tooltips, which is what this little box that pops up is called, just to provide that more complete picture. And then we also have it as rates. So per 100,000 residents, we provide this rate of Oregon firearm injury emergency department visits. So that is what we have right now. That's what's currently available. And it gives you kind of a taste of what the AVERT dashboard will look like. We are obviously making a lot of changes related to feedback that we've received from community partners, and also adding in these other data sources and providing and talking about a wider variety of injuries. But that just gives you a taste. So yeah, I wanted to open up, I can pull that dashboard back up if people wanted to see certain things. I know I didn't really give you a chance to digest those data. I wanted to just show you what's there so you can look at it on your own if that's of interest to you. I didn't expect you to be able to read any of that in the time that I had it on the screen, obviously. But yeah, I'd love to open up the conversation. Will, Susan, and I are here to answer questions, and also just to hear from you about data that you think should be included, data that are missing. Yeah.
Becca, can I ask you one thing? Hi, I'm Annette, and that incredibly useful stuff for our policy advocacy. Actually, it's really the way you put that together is so great. I'm confused about the AVERT. Like, what are the other kinds of injuries that it would be collecting other than firearm injuries?
That's a great question. So we are expanding. In the first stage, we're probably going to stick with starting with the firearm injuries, like we said, starting with firearm suicide. Some of the other syndromes, which is just the fancy word for the injuries that we're looking at, include youth violence, sexual violence, intimate partner violence, child abuse and neglect. Will, if you want to help me out on there, there's a long list.
I think that covers the violence related ones. CDC also lumped in mental health related conditions. We are still in the process of figuring out how to include that. We likely won't include those within the same dashboard related to violence, just because it feels kind of incongruent. And those are things like tic disorders, ADHD, schizophrenia, bipolar disorder. There's a bunch of them, anxiety disorder, depression. So we're kind of confused why CDC lumped those into this grant. I think they were hoping that in the 5-year period, we could also help to validate those. So yeah, it's an interesting inclusion, and yeah, we'll have to figure out. We'll probably have a separate dashboard for those.
Yeah, if we share them on a dashboard at all, because things like emergency department visits for ADHD, I mean, correct me if I'm wrong, people who are doing the work, but I'm not sure anyone's looking for that information. I could be wrong, but But yeah, we're really focused in terms of the presenting it on a dashboard. We're really more focused on the violence related injuries.
What about overdose data, given the fentanyl crisis? Is that bubbling up at all?
Yeah, so there's another syndromic surveillance project called Suitors, which is also sponsored or funded by the CDC, and that is focused specifically on overdose.
Great, thank you. Appreciate it. I was also curious about the poor sensitivity and PPE for intentional. And so what are the steps to really improve, that detection?
Yeah, it's really challenging within the data that we have. We can improve it somewhat by using the triage notes that we get from some of the facilities. The quality of those is variable. So in some cases, certain facilities will give us very detailed information that we can really use to determine this is a self-harm incident. And then others are relatively brief. It'll just be a pretty short statement that's more for the nursing staff or something like that. So state discharge data for both emergency and hospital admissions. Those have IC codes that are coded by professional coders. So they should have higher reliability. There's a known issue with the common EHR systems when a provider, is quickly just trying to chart. If they type in gunshot wound or GSW into the drop-down menu to get codes, it'll just default to that unintentional code. So about 70 to 80% of the records in essence by IC10 code are just going to be unintentional. So we really need to use other methods to be able to access that intent data and supplement with other data sources.
Thank you.
Yeah, we're
That's
also hoping to be able to link to EMS data because as we know, with the lethality of firearm suicide attempts, a lot don't make it to the hospital.
Yeah.
So we hope that could be a valuable data resource. We've also been talking to individuals from 988 and Lines for Life to try to see if we can get more at suicidal ideation and in conjunction with access to firearms. So yeah, we're really trying to explore how we can improve that and how we can provide valuable data when it's not always available from the main source we're using.
Right. Yeah. Well, thank you very much.
If I can just add to that, I think it was encouraging, at least for me, early in the faster part of this project that the CDC kind of recognized because of the validation going on around the country, that Essence, it's a weakness of Essence to try to look at it for intent, and community partners certainly told us that's an important part of this. So the CDC has been open, has said to us, use supplemental data. So that's what we're doing, the different ways that Becca and Will mentioned. So, but if there's any ways that all of you can think of, that we could be trying to get more to the suicide data or firearm suicide, because like Becca said, that's what we're focusing on in this first year of AVERT. We're doing like a deep dive into firearm suicide because we've looked at firearm injury in the FASTER project. And then we'll move on to the other violence related. But anything that you all can think of as ways that we can get more data, or have data that you need that other people aren't able to haven't spent the time to try to get, we'd be glad to hear from you about that. David, did you? Oh, I'm sorry.
I'm not sure about getting more data. I mean, I do think there's a really interesting overlay to the fact that we do this postvention work for 24 and under. It's tricky because ends up being a very small number of people. So trying to pull data from that, I think, but I don't know. It just strikes me that we have some really interesting information, for example, about how many of the youth are dying by firearm. And, certainly have heard multiple stories of, like, I sent my kid over to someone else's house and they got the firearm at the house. That I don't know. I wonder if there's something, it's more qualitative, but that there might be something out of that whole sort of experience and intersection we have that could be helpful in understanding, at least with young people, some of the firearm access.
I definitely think that could be very valuable. And yeah, the fact that it's more qualitative, that's okay. Like I said, we want to provide the context. Another area where we know that there's major data limitations is we want to be able to provide more data on intersecting identities, but Essence and the hospital records just don't have great information on gender identity, sexual orientation, representation for the LGBTQIA2+ community. And I saw that Anna Silverman was on the call. We actually we'll probably be in touch, just so you know, we had you on our list of people to reach out to. So flagging that for you, look out for my emails. But yeah, we're trying to figure out ways that we can do more than just say, I'm sorry, we don't have these data, because that's unfortunate. And we want to make sure that we are reaching and supporting populations that are disproportionately affected. And even if the data aren't there, we want to figure out how we can still stand that up. David?
Thanks. Great presentation. I had two questions. One was whether with the injury data, there is information about intoxication, like if someone's intoxicated with alcohol or other drugs. And then the other question was, you mentioned you have these other states that are working on these data. How much coordination and uniformity is there across the sites? Like, can the data be used to compare to other peer states, or just be interested in that? Thanks.
I can take the second question, or at least start to, and then I think I'm gonna pass over to Will. He's definitely the one who's most familiar with, he's been on the project longer, and I like working with data, but Will is the expert. But in terms of the second one, I think part of the challenge with the cross-state comparison is that some of the Essence programs are different. Here in Oregon, most of our emergency departments and urgent care centers report, but reporting is voluntary. So you have to get the emergency departments and urgent care centers to buy in and agree to report. So I know we do coordinate with the other states. We have a quarterly all recipient call where we all get together and talk about what we're doing. For the data linkage portion of the project, we meet monthly with the other states also doing data linkage. So there is a lot of conversation and coordination. But actual comparison across states is a little more difficult given the limitations in some states. They may be working with a smaller proportion, But I'm gonna pass it over to Will. He can definitely speak to it.
Yeah.
Better.
Yeah, continuing on that a little bit, just with data sharing, that is definitely a challenge. So typically the CDC will do more of that work, looking across the jurisdictions. They published a paper or a MMWR for FASTER, looking at the social vulnerability index by county for all 10 sites. So they have a little bit more of that ability. As part of the grant, we provide them with data by age groups, and then sex, race and ethnicity, county, and each of the syndrome definitions. There may be a couple other things in there that I'm missing. So the CDC would be the ones typically, I think, that would do those comparisons. We have connected with our counterparts in Washington and would definitely be interested in working with them. We do see patients, and this is one challenge with Essence. If, let's say I'm an Oregonian, right, that is visiting Washington and I get a firearm injury, unless I'm transferred to OHSU or Legacy or receive subsequent care at an Oregon facility, I wouldn't show up within the Essence data for Oregon. So it would be interesting to compare across the states. Beyond Oregonians, the largest number of folks we see are from Southern Washington. So that would be an interesting avenue for collaboration, definitely, and some comparison. But it is challenging with data use agreements for Essence. In terms of intoxication, there are syndrome definitions that CDC has created to look at some of those things. And there are also, ICD-10 codes and whatnot that we could use to explore that. It may not be the best source. I'm not sure, how well those syndrome definitions are performing or how well that's categorized in the Essence data. But it's definitely something we could look into.
Thanks.
Okay, well, that was a very, very informative presentation, and thank you so much for coming and sharing the information that you do have. Stay tuned for next steps, everyone, in terms of, where do we want to go as a committee in terms of understanding this or helping to inform, their work, or even informing the work with the Alliance overall. So thank you very much, Will, Becca, and Suzanne, and most of them.
Can I slip in one last question, or are we needing to move on to the next item?
No, go ahead.
I guess I just wanted to acknowledge that the legislation that just passed through the state about this new task force on community safety and firearm suicide by firearm. And I'm assuming that they're working with you at OHSU. And I just wanted to put out there that I really hope we can work closely together to support that task force and also to understand and leverage the opportunity of that for suicide prevention. Don't know if you all are talking about that there at OHSU or not.
Yeah, no one's told us that they're working with us.
We haven't heard about it, and that, like, as far as like us being involved, we've just been I know Kathleen did testify in favor of it. She was asked to do that by the committee, but
I'll just say from the outside, it looks to me like they're thinking of you all.
Yeah, that would be good, but we haven't heard from our end. Maybe, yeah.
Yeah, so maybe just if we can agree to stay in communication about that and try and, because I'm trying to sort of sort out what is that going to mean on the horizon for us, and that it's got some pretty high, I think they're trying to put some pretty high level decision makers on it.
Yeah, I mean, we would love if they are thinking of us, and if that is true, and we will definitely stay in touch. And we want to make sure that any recommendations and anything that task force does and thinks about takes into consideration all the work people are already doing.
Yeah, that's good.
Awesome. Thank you for letting me intercede that.
No worries. So thank you again, and hope to hear back from you all at another time.